The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
The province faces a $60 billion shortfall in healthcare spending over the coming decade. That, according to last week's report from the Financial Accountability Office of Ontario. Tonight, we'll find out more with the author of that report. Then we'll hear from healthcare analysts on where they see the potential to reduce the surgical and diagnostic backlog and emerge whole from COVID-19. It's Monday, May 17th, and that's all ahead on the agenda. Last week's report from the Financial Accountability Office of Ontario outlined a multi-billion-dollar gap between what the provincial government intends to spend on healthcare and what it actually hopes to achieve. Add to that a surgical backlog that will take years to clear, and it leaves many questions to ask of Peter Weltman. He is Ontario's Financial Accountability Officer, and he joins us now from the nation's capital. Peter, it's good to have you on again. How are you managing?
Doing okay. We're managing. The weather's starting to turn, which makes a big difference.
Right on. Okay, good to see you again. Let's start by sharing with you and our viewers and listeners, and I'll go into some detail on this because those listening on podcast can't see the pie chart, but I'm going to ask our director, Tony Burke, to bring this up. This is basically healthcare spending 101 in the province of Ontario, where we spend more than $70 billion a year on our health. And let me just go through this briefly here. Hospitals make up more than a third of our healthcare spending. It's almost $26 billion a year we spend on hospitals. What we pay our physicians and health practitioners comes out to $17 billion a year. And then we keep going along. Capital programs, $2 billion. Long-term care, $5.6 billion. Mental health and addictions, $2.2 billion. Community programs, $4.9 billion. Public drug program, $5.4 billion. And all other stuff, more than $11 billion a year. That's how we spend money on healthcare in Ontario annually. Let's just start with this background. Why did you choose to focus on healthcare in this particular report?
This is a report that we did for the Standing Committee on Estimates. So every year around this time, after the estimates are tabled in the legislature, and the estimates are effectively the government's spending plans. So the government has $170 billion to spend, and it basically tables these to the legislature because ultimately the legislature needs to approve these spending plans in order to provide the government with legal authority to go ahead. So there's your political science background. This was a report done to analyze, provide an analysis of the Ministry of Health's spending plan for the Standing Committee requested from us by a member of that committee.
So these are essentially the numbers that are behind the budget speech that Peter Bethlenfalvy, the finance minister, gave on the 24th of March. You looked at it, you crunched the numbers. What was the overarching conclusion that you came to?
So we looked at Ministry of Health for this report, we crunched the numbers, and we broke the numbers out into the pie chart that you just showed earlier, because that's not how it is in the estimates. And the conclusion was the government's spending plans are not sufficient to offset the cost of the health program, neither now in the midterm, we find them going to be short about $5.6 billion in the next 3 years, and between now and 2029, 2030, we found that the ministry is going to be short a cumulative total of almost $62 billion.
A $62 billion delta over the next decade. What in effect does that mean?
Well, it means that the current healthcare system that we have in terms of how we use doctors and hospitals and what we pay people and the different drugs that we use, and that whole combination put together will cost us between now and in 2029-30 about $90 billion. The government hasn't allocated that much money, so the government has either got to basically find more money to close the gap and continue delivering the program as we know it today, or it needs to find a way to modify the existing program in a way that's acceptable to Ontarians and taking some cost out of that program, or it needs to find a way to raise more revenue to pay more money towards that program.
Does the government acknowledge the accuracy of your findings?
So I don't normally get a phone call from the government discussing the findings, but I think what I've seen is that uh, for the first 3 years, we're pretty close. I think the argument that always comes back from the government side is that, well, the government has approved the spending and that's what the spending is going to be. The FAO is simply just modeling, and it's a modeling number. So this is true. This is a modeling number, and we do that to provide a baseline for MPPs to use when they're asking the government to account for their spending plan vis-a-vis the baseline.
So in effect, this is the car's over by the side of the road and somebody shot up a flare into the sky, and this report is the flare saying that if you keep doing what you're doing, here's what we're looking at. Is that sort of it?
This is exactly it. And I think the same could be said for pretty much every report that we write with regards to a government program. That is the objective. Here is the program as is. Here's what things will look like in 10 years. If you are planning to make changes, here's how the changes will impact what that looks like over the next 10 years. We've done that for long-term care. And in fact, we're going to be doing that again next week with long-term care. We've done it for autism. We've done it for, cap and trade. So yes, that is exactly, I think that's a great way to describe what we do.
And I'm sorry to harp on this, but I really am curious about this. Are you saying nobody from the Ministry of Finance, nobody from the Premier's office, nobody from the Health Ministry has actually been in touch with your agency and said, holy smokes, that's not what we thought, so thanks for this information, and now we have to change our thinking accordingly? You never got that kind of interaction?
One thing about being a budget officer, you never expect that kind of interaction. That's not why we do the work. I'm not looking for somebody to call me and say, oh my gosh, you're, like the greatest thing since sliced bread. That's just not how the job works. So what does happen though, and I think it's important for people to know, is that when we do a draft report, we do send it over, in this case to the Ministry of Health, Ministry of Finance, and the Treasury Board, to make sure that there's nothing in the report that might disclose a cabinet record, or that maybe there's a factual inaccuracy in something that we're doing. In this particular case, we did receive cabinet records. We always do if we need them for analysis, and we had to leave some of those out, and that's normal. But other than that, no, nobody disputed we didn't have a long conversation about our findings. It was simply looking for factual accuracy. So by implication, then, they are factually accurate.
Let me come at this from a different angle here. Based on the research that you and your team did, were you able to come to any conclusions about whether the proportions of the health budget being spent on, for example, hospitals or mental health or long-term care, are we spending money in the correct proportions, or did you look into that?
We don't look into that. So I think it's important to know what we do. We're a small team, remember, like a total 20 people, including me. And we're doing a bunch of other work too. So this report is simply there to help MPPs understand the breakdown of the Ministry of Health spending, what the spending looks like over 10 years against the program cost. We did get into some detail around program areas. We looked at the gaps between our projections for the different program areas, such as like mental health, as you mentioned, or community drugs, or hospitals, OHIP, et cetera. And there are a couple of significant gaps between our projections and then the government's in a couple of the program areas. But that's as deep as we would get in a report like this. Now, it's possible that an MPP may ask us to go deeper, if you will, into one of these program areas, or to expand on what's going on in hospitals or what's going on in whatever OHIP, but that's not what this report does.
I am going to ask you to go deeper now on one thing in particular, because this did get a great deal of currency and attention this past week. We know that hospitals had changed their mission from doing basically everything that they're asked to do to focusing in particular on COVID-19. And as a result, a lot of surgical and diagnostic procedures have been postponed. And Tony Burke, I'm going to ask you to bring this next chart up here, because this is the estimated cumulative backlog of elective surgical procedures. All right, if we go back, and again, for those listening on podcast, I'll describe this in some detail. If we go back to when the pandemic first hit, so March 2020, the backlog of surgical procedures, elective surgical procedures, was not all that significant. But we see what's happened to that backlog as soon as COVID hit. And the numbers just keep going up and up and up and up and up. And you've got a forecast on the assumption that we continue at the same rate, presumably. You've got a forecast that sees us with more than 400,000 elective surgical procedures waiting to take place. That's the backlog as we move towards September of this year. Okay, simple question to get us started here. How did we get there?
We got there because we told hospitals to stop doing elective procedures. That's how we got there. It's not like people suddenly didn't need to have the surgeries. The hip replacement didn't replace itself, for example. That's how we got there. How did we come up with our number? We used ministry data. So the ministry did publish a recovery, if you will, plan back in May of 2020 because elective procedures were shut down in the first wave once the pandemic hit. And the government did publish sort of a backlog at that point, and it published a timeline for recuperation, if you will, or to try to get back on the backlog. We never quite got there. We had a second wave in the fall, which slowed things down. And now we have a third wave. And as of April 2021, all elective procedures again have been canceled. So this forecast takes into account the government's methodology, the projection methodology. We just overlay more current data that we received again from the government to project out to 2021. And we assume that the lockdown or the elective surgery moratorium would last 9 weeks. We'll see, because that's roughly what it would have lasted back in May of 2020. So we use a similar process, and that's where we end up at the 419,000.
Let me use your example that you just did. If I'm a person waiting for hip replacement surgery and I was told by my surgeon, okay, we know you need it now. We've got you booked in for 2 months from now. Because of this surgical backlog, what are they more likely looking at rather than 2 months?
Well, that's a great question. And I think it's not one that I can answer. I suppose it depends on the judgment of the physician, the surgeon, the hospital, whoever makes the decision as to whether this is purely elective or if it starts to move into a non-elective category. And I guess at a certain point in time, most elective surgery or a lot of elective surgeries will probably move into an emergency category if they're not dealt with early enough. But it's an issue that we thought would be great for MPPs to ask the government, because it is, their ministry, their plan, and we're just putting the numbers up. We're, like you said, we're lighting the flare to say, hey, we're going to have a big problem. And our 419 our 419 is based on, I said, their methodology.
Your 419,000 backlog is what you're referring to.
Yes, that's right.
Yeah. All right. Well, funnily enough, I'm one of these people who has a sad predilection to watch Question Period every day. So I know for a fact that opposition MPPs are asking the questions that you just suggested. And the government response to date has been, we're spending anywhere from $500 to $600 million in the current budget year to ensure that this backlog gets dealt with. I guess two questions emerge from that. Number one, do you have any evidence that proves that in fact is happening?
So first, our answer is no. That's not, again, part of the report. So we aren't the Auditor General. We aren't actually looking at what's happening on the ground today or what happened on the ground last year. This is a forecast. All right.
In which case, as you model forward your forecasts, let's take the government at their word. If they are spending, and I'll give them the high number, if they are spending $600 million to eliminate this backlog, by your counting, will that get the job done?
It'll get half the job done by our counting, so they're going to need to double up. Our number is 1.1 to clear the surgery backlog, another 200 and change to clear the diagnostic procedures backlog. Now, the reason for the discrepancy is the budget came out before really the third wave hit and before the moratorium on elective surgeries, which was imposed in April of 2021. So to be fair to the government, their budget was done up before all this happened. So our projections show they're going to need to come up with more money.
And have you, well, and again, I don't know if you'd be the guy that they'd tell, but is there any indication that you've seen so far that the government is prepared to up that amount of money they intend to spend to clear the backlog if they're, as you say, $500 or $600 million short?
So again, no, nobody is calling me to tell me that they are reading my report and our report, and they're going to, write a check for another $700 million on our say-so. That's just, again, not the way things work. I don't know what's happening within the Ministry of Health, but I do know they're considering these numbers. I mean, they knew about them, as I said, at least a couple of weeks before the report came out. and nobody took issue with it. There were no factual inaccuracies in our methodology. So it's a reasonable projection.
Yeah, I guess I'm glad you pointed that out, because we should say that your office is based on a federal office that was set up several years before yours was. And it was not unusual for example, the previous Stephen Harper government, when they didn't like the numbers coming out of the federal equivalent, they would attack it was Kevin Page at the time. They'd attack him in public. I remember Jim Flaherty doing it all the time, saying, we don't like your numbers. We think you're wrong. To be clear, nobody from the province is saying that to you. Is that right?
That's right. That's right. No, I lived through that era at the Parliamentary Budget Office, and we've been very careful to make sure that our forecasts are reasonable, that the government to look at the factual accuracy, if you will, or the facts of supporting the assumptions supporting the forecast, and that's built into our legislation. So we're required, and our internal processes. It wasn't something that was done in Ottawa. There certainly wasn't I don't want to spend a lot of time on that, but it wasn't conducive at the time to have that sort of relationship.
All right. Can you come, as a result of the work that you've done, to any overarching conclusion about what condition the Ontario healthcare system is in today as a result of the shellacking, if for lack of a better word, it's taken because of COVID-19?
So again, the report doesn't kind of, assess the state of play of the current system, but I think it's fair to say that it has taken a shellacking, and it's not machines so much that you worry about, it's people. It's the staff, it's the doctors and the nurses and the specialists and the folks that you need to support all of those procedures and all of everything that happens within the system. And they've taken a shellacking. And that shellacking, given our elective surgery forecast, is not done yet. So on the elective surgery forecast, yeah, we've put numbers out there showing if hospitals were running at a pre-pandemic level of normalcy, it would take you 3.5 years to get through this, through the backlog. But our hospitals have not been, necessarily able to keep up. We talk about that further down in the report, how hospital capacity has shrunk by per 1,000 people over the last 20 years. So there's still a big problem, the after effect, or the aftershock, I guess, comparable to an earthquake, of dealing with the pieces that the shellacking has left behind.
We should do one more example on this, and we're going to do a deeper dive in the panel discussion that will follow this interview. But you didn't just look at the surgical backlog, you looked at the diagnostic procedure backlog as well. And let's say there is a woman who is watching this right now who perhaps has found a lump in her breast, and she needs a biopsy to determine whether that's something she really needs to worry about. Is it your finding that under normal circumstances, if the government doesn't do anything, there's going to be a 3.5-year wait for that procedure?
Well, as I said before, this is, again, these are great questions, and these are questions I'm sure that are on people's minds. The doctor or the surgeon or whomever makes a call as to whether or not this is considered to be an elective procedure or an emergent or an emergency procedure, something that needs to be done right away. And that falls outside the purview of the report. But it does bring, home the point that somebody's elective procedure is somebody else's emergency procedure, and where is the line, and how does that get decided? And I suppose that's the same process that's used when people come into an ICU and you have to start making decisions as to who gets what sort of treatment based on a whole bunch of different conditions. So it doesn't make it easy for those healthcare workers who have already been shellacked, and it certainly makes it, it certainly raises the anxiety level of folks that are sitting waiting for some sort of a screening procedure to happen and looking at these numbers and saying, oh my gosh, how long do I have to wait before maybe what something is benign turns into something that's not so benign?
All right, let's go into the home stretch here. And you have already pointed out that one of the ways in which this backlog can be attacked is if the government simply doubles spending and creates more capacity for the system to deal with it. Is a more efficient way of doing business also, in your judgment, an option for tackling this backlog?
So there are always more efficient ways of doing business in any business, including the business that I'm in right now. We always look for ways to sort of, optimize the resources that we're given. I don't know enough about the system itself, but certainly, I think if we look at other jurisdictions in terms of how they organize their healthcare and their procedures, that there may be ways to to optimize what's going on to try to deal with this backlog. I mean, certainly one way to deal with the backlog, apart from just throwing more money at it, is you still need to find the surgeons and the support staff and the physical assets and equipment and beds to handle the backlog. So maybe you start looking at other jurisdictions to help you handle the backlog. The problem in a global pandemic is that everybody's in the same boat. It's not like some people have all kinds of spare capacity. So this is a real conundrum. And luckily, it's not within my mandate to try to figure a way out of it, but it is within my mandate to bring it to the fore.
No, indeed. And again, going back to question period, I have heard the health minister answer questions about this in question period by saying, we never used to do nights and weekends when it came to these things in the past, but now we're doing more of that, and that's helping deal with the backlog. Now, presumably, that's finding an efficiency in the system today that you may not have had a year or two ago. Is that a reasonable answer?
I think it is a reasonable answer. So you're re-engineering or rethinking some of your existing processes. Another one that was done was moving patients to where the surgical capacity existed. So if they were sitting in a hospital in Ottawa and there was no surgical capacity and they were moved to Kingston, where there was, that's not something that was done before. And I know from firsthand people that I know in the business who have, said that there are a number of rules around having to do that. And a lot of those rules were modified because of the emergency nature of the pandemic to allow people, hospitals to move people to where the services were available. So certainly that's an option as well. So there may be lots of those sorts of things that we used to do in the past, that we don't necessarily have to do in the future to alleviate a critical problem. I think another thing that comes to mind, the simple one, is being able to do, healthcare visits with your doctor over the phone or over the screen. That was not something that was common before, and now it's become very common. And it really required a couple of simple changes in procedure to allow doctors to start to bill OHIP for those visits, for those virtual visits. It was a couple of extra billing codes that was probably in discussion for years and years. And then after the pandemic hit, it took about, 2-3 weeks before that got done.
Never let a good crisis go to waste, as the expression goes.
I'm not going to say that.
No, I understand. Let me ask you one last question. And that is, you did give me a hint just a moment ago in one of your previous answers that you're looking at long-term care now. I don't have to tell you what an absolute catastrophe long-term care has been in this, everywhere in the country over the last 15 months. Can you give us some hint as to what angle you'll be looking at in that regard?
We're looking at, we did a long-term care piece about a year and a half ago where we said, okay, you have this size wait list, you have this many beds, you're going to add 30,000 beds over the next 10 years. What's that going to do to the wait list? What's that going to do to the number of folks in care, et cetera, et cetera? So that was a decent piece as a baseline before the pandemic. And it found that by adding the 30,000 beds, you're not even, standing still, if you wish. You are barely keeping up with the demand because the population of Ontario, the elderly population, those 75 and over who are more apt to end up in long-term care, is growing far more rapidly than the population as a whole. So when you have your client market growing very rapidly, if you're not, providing enough supply, to use the old economic supply and demand, theory, that you're not providing enough supply, you're going to have some way, you're going to have a bunch of people waiting to get into long-term care. What we do in this report coming up is we look at more detail some of the government's plans on adding new beds, renovating existing beds to make them more code compliant or modernized, and the cost of adding all of the extra care that they've talked about adding.
Well, that's our time for this evening. I guess I should just finally say that I did hear you on the Hurley Burley podcast with David Hurley not too long ago, during which time I think you dropped one little word of profanity, which I found very endearing, actually. And I'm just a little disappointed you didn't drop one today, although there's still time if you care to.
So I am, let's say, frustrated a little bit. You had to remember, I have members of my family watching and making sure that I stay on the straight and narrow here. So frustrated that the government will come out with a plan to say, yeah, we're going to balance in 2029-30, and how we're going to balance is we're going to basically cut healthcare spending to below the level of demand. We're going to cap it rather at a certain level, and there's going to be a gap. And it's a $62 billion gap. And yeah, it's a very abstract and it's a big number and it's far away in the future, but this is a problem that's been happening for, we knew about it 40 years ago, 50 years ago. I think you mentioned in one of your books about, Bill Davis and at the time the health minister having a chat and them saying, thank God we're not health ministers 40 years from now, because boy, we're going to have a big problem. It's fun being education minister back in the 60s. So this is a problem that's been around for a long time. It's not getting better. It's getting worse. The pandemic, I think, has really, like you said, shellacked us and exposed a lot of the issues with the system. And I think also exposed a lot of the amazing work that's done within the system to contain and to support folks during this time. There needs to be a discussion as to how much of this can we pay for going forward and how we're going to do it so we can keep ourselves and our population healthy and productive.
Well, hopefully we prompted some of that discussion here this evening. And Peter Weltman, we're always grateful for your time and enjoy your visits here on The Agenda. That's Peter Weltman, Ontario's Financial Accountability Officer. You take care, okay?
Thanks, Steve. You too.
Bending the healthcare cost curve was an ongoing concern before the pandemic hit. Now, with so much upended by COVID-19, as the Financial Accountability Office laid out, can the province find a way forward? On that, can we welcome in Vancouver, British Columbia, André Picard, health reporter and columnist for the Globe and Mail. In Waterloo, Ontario, Rosalie Wanch, health policy economist at the C.D. Howe Institute. And from Little Italy in Ontario's capital city, there's Sheila Block, senior economist at the Canadian Centre for Policy Alternatives. And it's great to see you three back on our airwaves again for, as we like to call it, an important and timely discussion in light of the FAO's report that just came out last week. Sheila, to you first. Let's just start broad strokes here. What story, in your view, is this report trying to tell?
I think this report is saying no matter how you slice and dice the numbers, this year's budget did not have the money required to do what the government has promised it would do in the budget.
Rosalie, how about to you?
I would say I agree. It really shows the level of the challenge that we're dealing with in terms of both increased costs, decreased revenues, and a lot of work that needs to be done in terms of fixing some of the gaps or problems that we had with the healthcare system originally. So I'd say it shows quite the challenge.
Andre, what's the story for you?
Well, very similar to the other two, sort of a constant fudging of the numbers when it comes to healthcare. And this has just really underscored it in a very graphic fashion, a big shortfall over a long period of time.
Well, no fudging in the numbers coming out of the Financial Accountability Office, to be sure, and we're going to do a deep dive here on one aspect of the report. We touched on this with Peter Weltman, but now we've got some numbers to back it up. So, Tony, I'm going to ask you to bring up a shot here of the diagnostic testing backlog now facing Ontario patients. And for those listening on podcast, I'll go into some detail here. If we go back to the beginning of the pandemic, that's March 2020, you can see on this chart there is very little backlog at all to speak of. But then as the pandemic takes root, the numbers really go up and up and up a lot. And today we're looking at a non-emergent diagnostic procedure backlog of 1.6 million procedures. And if the current rate continues, the FAO has got that estimated by September to be nearly 2.5 million backlogged procedures, which the FAO estimates could take 3.5 years at current spending rates to clear. That clearly is not acceptable, I would assume, to the people of Ontario. But Andre, let's just remind everybody what the FAO is talking about when they're referring to this kind of a backlog. The services that this would include, non-urgent diagnostic services, means what?
Well, mostly surgeries, so not urgent surgeries, but elective surgeries. So there have been, as the report says, millions of procedures delayed, put off, and we're going to have to catch up at some point. And the question is, how do we do it? We can't magically add doctors and nurses. Operating rooms were already full. We already had shortages of staffing. So this is a problem. And these numbers really underscore just how severe the problem is. But the solution is a lot less obvious.
And this chart actually is not even elective surgeries. This is just the diagnostic procedures, the biopsies and that kind of thing, which I mean, if you're somebody waiting for a diagnostic procedure right now, Andre, this can't give you a lot of comfort, I presume.
No, this is essentially, yeah, I should have stated that more clearly, the prep before the surgery. You have to be diagnosed, etc. So waiting for scans and things, no, it's a time where people are very worried. They don't know the results. They don't know what's going to happen. And this was a problem before COVID. We didn't have a big backlog, but it was sort of always trying to catch up. And it's just backlogged terribly. And again, it's not clear how the catching up will be done in any quick fashion.
Rosalie, could you give us your characterization of the significance of those numbers?
Certainly. Really, I think that the number of people waiting or tests that we haven't done sort of speaks for itself for this size. But what I'm more concerned about, and sort of echoing Andre, is that those numbers don't include the considerations for, do we have the capacity, do we have the staff to actually be able to deal with the backlog in the time that the FAO is projecting? Because they're assuming that hospitals can operate above capacity for that entire period. And we're thinking about 3 years. So my worry is that all of that delayed diagnostics will actually mean that once we do get to diagnosis and people reach treatment, their case might be more complex, which could come with health consequences for the patients, but also increased costs for the healthcare system. And so I suppose, though that number is somewhat alarming as it is, my worry is actually that it might be too optimistic in terms of how quickly we'll be able to deal with the backlog, and that it might not include added costs because we've not found something during that backlog.
Well, that raises an interesting question because, okay, Sheila, Peter Weltman, the Financial Accountability Officer, in my interview with him just before you guys came on, said that essentially the province is going to have to double the current spending it currently budgets in order to clear that backlog. Rosalie raises the issue that even if they did that, do we have enough doctors? Do we have enough nurses? Do we have enough OR capacity? Do we have enough diagnostic tools to be able to do it anyway? What can you tell us on that?
Well, I think there are a number of ways in which we can start to address this. One of which is we have internationally educated healthcare providers that we could, fast track into service in this kind of situation. And we have to really take a hard look and see what capital expenditures would need to be made, what kinds of investments do we need to make in more healthcare providers. And I think we really have to look at what we have done during the pandemic and step up in the same kinds of ways that we stepped up then. And I really think that we have faced decades of underinvestment in healthcare in Ontario. And as a result, the chickens are coming home to roost here. And I think we really have to take a hard look at what we need in the healthcare system and how we're going to pay for it.
Well, let's do another chart here. And this again is from the Financial Accountability Officer's just completed report from last week. And Rosalie, I'll get you to start on this one first because this chart really piqued your interest. And I'll ask Tony Burkar, who's directing today, to bring this up if he would. Healthcare program funding. And these are the areas that the FAO has identified as facing potentially significant funding decreases over the next decade. Operation of hospitals off almost 20%. Regional coordination operations support off almost 70%. Small hospital projects off almost 90%. Digital health down more than 40%. Home care down 3%. This is something that theoretically we're supposed to be relying on in our future in order to ensure our long-term care homes don't become overrun. 3% decrease in funding. Outbreaks and diseases more than 20% off. Child and youth mental health, almost 15% off. Rosalie, what's the story you're seeing in those numbers?
Well, really, some of those are understandable. The decrease in small hospital projects is really being replaced by large hospital projects. But really, some of those, I suppose, are puzzling and possibly a little bit worrying for me for the future, just because when we're looking at sort of the gaps or the problems that we've identified during this pandemic and before, youth mental health, I would consider to be a bit of a concern considering all the disruption that children have gone through in the past year. Digital health is really a tool to reduce costs in the healthcare system and get people easier access. And we've made great strides in actually doing that over the last year. And so the reductions or these negative numbers in some of the areas that have been identified as priorities simply by the situation that we're in does sort of make me question if we are going to really learn the lessons that we should be learning from this pandemic, in terms of we need to think about how we deliver healthcare differently, and home and community care, mental health care are very much part of that. And though the government is investing in those areas, I wonder if we're missing the opportunity to really have a major paradigm shift in healthcare and really address some of those chronic issues that we've been seeing. And with that, to move forward on those issues, I would expect that we need some investment in those areas. And digital health, outbreaks in disease, home care, and youth mental health, I would think are all areas of priority, particularly given recent experience.
Andre, just before I get you to weigh in, I should just remind everybody that this is potentially what the future looks like over the next decade, if, as the FAO says, the government of Ontario doesn't fund healthcare to the tune of $60 billion. That's the gap right now between apparently what we need and what the government is budgeting. So if that $60 billion gap persists, those kinds of numbers are what we're going to be looking at over the next decade or so. What story do you think it tells?
Well, I think very similar to what Rosalie said, it seems to be a disconnect between reality and what's needed. You know, with the investment in mental health and home care and digital health, those seem like obvious priorities in the wake of COVID-19, and they seem to be being reduced. Some of it, again, as she mentioned, makes some sense. You know, there's a big reduction in, I forget the exact category, but administration, and I think that's a shift to the Ontario Health Team. So some of it's understandable, but overall, some of it is very puzzling. You have to worry and wonder about government priorities.
Sheila, does it make you wonder as well?
I think this government's priorities are pretty clear. They are focused on the bottom line, and I think they're focused on the bottom line to the detriment of public services. And I think really what we want to drive home here is this report says, can the government fund what they said they're going to fund? I think there's a whole view on what they've said they're going to fund is not actually sufficient. You can look at the timing that they're going to take to get up to 4 hours of care in long-term care. You can look at the de-skilling of long-term care workers. You can look at what we're going to do with the real crisis that nurses are facing as a result of this pandemic and policy in response to it. And you can even think about the legal challenges about nurses' remuneration. And if the government loses those legal challenges, then they will be even further behind in the funding of what they want to do.
Well, Andre, let me play devil's advocate for a second and say what the government probably would say if the Minister of Health were participating in this discussion. And that is, look, we're spending north of $70 billion annually on healthcare in Ontario right now as it is. Surely, she might argue, that's enough to deal with all of the priorities we have. What's the response to that?
Well, maybe it's enough, but I think we don't spend enough time thinking about, are we spending appropriately? Are we getting value for money? So it's not just about doing more of the same old, which tends to be the way that government budgets operate. Is we've spent X billion last year, we're going to add 2.2%, and that's that. So there's never been, and there rarely is, a fundamental rethinking of how we spend and where we spend. And that, again, is, I think, an opportunity that COVID-19 should have given us, is to really rethink, are we investing properly in elders, in home care, in mental health? And this seems to underscore that we're actually not really thinking about this at all. We're just talking about just the numbers. Can we hold the line? And it, I think, raises really serious questions about how will the government, if it feels it's spent enough, how will it control spending? Because in the past, how have they done it? They've frozen the payments to hospitals. They've tried to control doctors' salaries. They've cut back on nurses and pay to nurses. All these things have been monumental failures. So if the government line is we have to spend no more than this, well, tell us how you're going to do it is the most important discussion, I think.
Sheila, let me pick up on one aspect of Andre's answer there and put it to you, and that is that every healthcare expert that we talk to, and Andre wrote about this in his most recent book as well, every expert says older people want to age in their homes as opposed to hooked up to tubes and lines in a hospital bed. And the way to make that happen is to increase funding for home care, perhaps, but not necessarily at the expense of more money to hospital care or long-term care. The expression we hear all the time is we don't want to warehouse seniors. We want them to age appropriately in their homes. When you look at that chart and when you look at the priorities that the Ontario government has enunciated so far, do you see that approach being put into effect?
I don't see that approach being put into effect. And I think we have to not only look at that approach as a way to reduce healthcare costs, but I think we have to look at it as how do we enhance the quality of life? And I don't think that, an immediate kind of removal of money from hospitals or reduction in long-term care and reinvestment into home care is really the way to do this. I think what we need to do is increase investment in all of these sectors, and then we can kind of take a look at it and see how are we increasing the quality of life. And there will absolutely be some positive outcomes. We know that many seniors are in hospital waiting for either home care or long-term care. But I think the objective really should be quality of care and quality of life.
Rosalie, do the numbers that we've just put forward suggest to you that the government seems committed to improving the home care budgets, improving the long-term care budgets, and so on?
Well, I think that they've made commitments, especially because of the results we've seen, the public demands that we really do something about the situation that occurred in long-term care homes. But really what I think when we're talking about all of this investment, and I agree that there are issues that all of these issues need to be dealt with, but at the end of the day, we already have a gap in what's promised, sort of what we already have on the table already looks somewhat unaffordable. And then with the FAO projections looking out 10 years, the gap between what the government projects and what the FAO projects is equivalent to almost the entire post-secondary budget. So we can't invest everywhere in healthcare. We can't just keep spending more there. What we need to do is be incredibly strategic about where and how we spend that money. And otherwise, healthcare seriously runs the risk over the long term of crowding out other program spending or quite significantly increasing taxes. And so though we can talk about what we would like to do in an ideal world with all the resources available, there really is the unfortunate fact that government revenues have also taken a hit, and that investing in one place means that you can't invest somewhere else. And though we do need to invest in our healthcare system, I worry that if we focus too much in one area, we will neglect all the other areas of program spending, public services, that really, it's the collection of all of these programs that contribute to people's health and quality of life and keep them well. And so I think we don't want to invest in sick care if it at the expense of crowding out preventative care and high quality social determinants of health. So thinking about welfare, education, and really there isn't an infinite amount of money. And so we do need to be strategic, but at the same time, we have quite large priorities that will be expensive. So I'm sympathetic to the idea that this is an incredibly difficult challenge, but that just choosing where to spend the money won't be enough. We need to think differently about how we're going to spend the money so that we can actually afford high quality care for everyone.
Well, in fact, I've been hearing health ministers across the country talking that way for the last 3.5 or 4 decades. And Andre, maybe I'll get you to weigh in on this. I've been told, well, we've all heard over and over again that the healthcare system really has to stop singularly focusing on being a sickness treatment system and has to start encompassing ideas of health promotion and wellness promotion. Are we doing that yet adequately in your view?
Well, the short answer is no, we're not anywhere close to doing that. And I think what Rosalie said is really important. We have to be careful to not just say we're going to keep spending on sickness care over and over. We've seen this particularly in Ontario in the past. What they've done is, slash welfare budgets, housing, public housing support, et cetera, things that keep people healthy in the first place. And that is a losing proposition in the long run. So we have to be careful to find that balance. It's true that money isn't unlimited, so we have to make choices. And I think one of the most important policy discussions we need to have in Canada, and we've been putting it off for decades, is, well, what do we cover publicly and what must be covered privately? And people don't like to hear that word, but we have a lot of private funding in Canada now. We just don't necessarily do it in any coherent fashion. It's not clear what's covered or why, and we have to have those discussions more broadly and openly.
Well, and different provinces, Sheila, cover different things. And that kicks off, I think, a little conversation I'd like to have here about comparing and contrasting Ontario with some of the other provinces. And let's start, for argument's sake, with Quebec. We noticed that Quebec ramped up spending and training to create more personal support workers after the first wave. And Ontario eventually brought out a similar policy in which they offered to subsidize the education to create a whole new generation of personal support workers in the third wave. Why were we apparently so late to get on that train?
Well, that is a devastating question. And I think there's a real question when governments realize they've made an error and move to correct it, and governments who don't. And I think the clear policy that the government has had through the pandemic, and particularly in long-term care, is their response was to kind of loosen regulations and to leave wide room for providers to move through them. And for example, BC very early on said you can't move from one home to the other. Ontario said the same thing, except they said if you're a temporary worker, you can move from one home to another. And
You're
as a result,
PSWs in one home only.
One home only. And so those kinds of policy responses from the Ford government have very much so cost lives. And I cannot give you a policy reason why they did that. It's truly distressing, and I think the Long-Term Care Commission kind of laid that out very clearly.
Andre, maybe I'll get you to make another comparison between Ontario and the province of Quebec. Quebec has what they call the Ministry of Health and Social Services. We don't. We are only the Ministry of Health in Ontario. Now, maybe that's important or maybe it's not. You tell me.
I think it's symbolically important. I think, in Quebec, the Ministry of Health is dominant, much more than the social services. But I think they understand better that these things are linked, that, making sure community clinics offer welfare services. A good example I like to use in Quebec, they have a program where if you go to your local community health center called CLSCs in Quebec, a pregnant woman will be prescribed orange juice and milk and prenatal vitamins. So this is an integration of this. Let's keep people healthy to ensure they don't have low birth weight babies. So that's just an example. If you have more integration, you have smarter policies. But Quebec isn't magically better, but on that count, I think they are a little more thoughtful, and they realize that this is a whole continuum that's not just about sickness care, it's about taking care of people, ensuring they're healthy in the first place.
All right, Rosalie, let's do another bit of comparing and contrasting here. How about hospital beds? The number of hospital beds per capita in the province of Ontario, say, compared to the other either 9 provinces, or if you want to include the territories too, how are we doing?
Well, Ontario is a little bit below the Canadian average, and unfortunately, Canada is, not doesn't fare that well on an international comparison either. And so I would say there are, relative to the size of the population, there are generally a shortage of hospital beds everywhere in the country, but as well, Ontario is a little bit below that average. And so there is it just shows the situation that we were in going into this pandemic, that there were, potentially not enough hospital beds for the size of the population. There was a large wait list for long-term care. And so I think just really, as Sheila said earlier, the underinvestment and the chickens coming home to roost, it's simply that you can't create that capacity overnight. And as a result, you end up with a lower capacity, less ability to maintain elective surgeries. And so really it just results in the situation that we're in now, which is that tough problem of we need more beds, we need investment in home care, we need to address the situation in long-term care. And meanwhile, there still is, we've been spending at an almost fiscally unsustainable rate, yet we still have these issues. So we've just really been digging a hole, and COVID just really sped up our say, downward trajectory. And now that's where we are, and we need to figure a way out of it.
Well, you've nicely set, yeah, sorry, Sheila, you wanted to add something?
I just want to leap in that absolutely we don't want to invest in healthcare at the expense of other services, and in particular in the social determinants of health. But I think we really have to be clear that there are fiscal options available, and that includes increasing taxes. That includes some renegotiation with the federal government if we're willing to kind of meet some of those long-term care standards that have been spoken about. And so I think really the lesson from this pandemic is we need a shift to a greater amount of economic activity in the public sector, and in particular in the caring economy. And it's not an infinite amount of need, and there are resources in the richest province that we could actually put towards them.
Well, you anticipated exactly where I wanted to go next in our remaining moments here. No, that's perfect, because this is exactly the question. I was going to say, for those of us old enough to remember the old game show, this is the $64,000 question. But apropos of what the FAO has just said, no, this is the $61 billion question, which is if we're going to deal with that gap in what the government wants to do and what it apparently has been prepared to fund, we got to figure out either how to find $60 billion or reduce other programs by that amount, or borrow more or tax more, or what. And I want some advice from all of you on that. Okay, Andre, we know what the options are. What's the way to go?
Well, the way to go is we have to recognize that we want a certain level of services, a certain quality of life, and we're going to pay for it. So we have to figure out the way to pay for it most efficiently. And the way to do that often is with collective programs. So let's find the public programs that are most efficient, that give us the biggest bang for the buck, and invest well there. And then there has to be a portion that is left to people funding privately, either with private insurance or out of pocket. But we have to find that right mix to be. Either we pay from the left pocket privately or from the right pocket publicly, but we have to find the perfect blend to get value for money and to give people good quality of life.
Now, Rosalie, I cannot imagine that a representative of the C.D. Howe Institute, which is a business-friendly think tank, I think we can say that, I can't imagine you're going to agree to $60 billion in corporate tax increases in order to fund this gap. Or are you going to surprise me today and say, yes, you are?
Well, I would point out that the corporate income tax take in Ontario was a little under $12 billion last year. So it would need to be not a small increase to cover the gap between the projections or the total amount. And so I think that it would be, shall we say, optimistically, it would be very distortionary, likely, if we were to just fully fund that amount with taxes. And I would say, even if we were to do that, there would still be the concern about healthcare spending growing faster than the revenue base or our GDP. and that at the end of the day, whatever the level of spending we have on our healthcare system, we have to ensure that it is fiscally sustainable, or we'll just simply find ourselves in another tough situation down the road. And so I think that there's
let me jump in here because I got a minute. Forgive me, Rosalie, I got a minute left here, and I want to make sure Sheila gets a chance to respond to what you said. And I'm going to put the opposite question to you, Sheila. Are you really prepared to stick business with $60 billion in new taxes to pay for this at a time when so many businesses, not Amazon, but others, not Walmart, not Costco, but others, are having such a difficult time right now staying afloat?
Well, I think it's a false, it's kind of a disputed question. I think what we can absolutely say is we would phase in these tax increases. We have to remember that right now, the cost of government borrowing is at historic lows. We do not have to pay all of this upfront immediately. A phased increase in taxes, absolutely all of it is not going to be on corporate income taxes, is the way to do it. And we would want to balance that with economic recovery, and absolutely it's doable.
I want to thank our three finance ministers for coming on the show tonight and explaining how this is all going to get done. Andre Picard, Rosalie Wanch, Sheila Block, it's great of all of you to spend so much time with us on TVO tonight. Thanks so much.
Thanks for having us.
Thank you.
Thanks.
And that is the agenda for Monday, May 17th, 2021. Tomorrow we'll find out why sometimes being told to look on the bright side just feels like toxic positivity. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
The Agenda is always on. To catch up on conversations from this week or any week, visit our website, tvo.org/theagenda, or our YouTube page at youtube.com/theagenda. It's all there for whenever you want to watch.